All right, hi guys, I'm Leidy. I'm a PGY3. Today I'm going to be giving a social EM lecture on giving trauma-informed care today to patients who have experienced intimate partner violence in the ER. Can everyone hear me? Is it loud enough? Okay. And just as a note for a content warning, today we're going to be talking about sexual violence as well as intimate partner violence, physical violence. Sadly, there are a lot of patients that I've cared for in the last couple of years who have experienced this in the emergency room as well as the inpatient setting. These are the learning objectives for today. I'm not going to spend a ton of time right now on them. After the lecture too, later in the week, I'll send out like a Canva that just kind of summarizes everything in a nicer, more aesthetic way. But just getting started with some definitions. Also before I get started, I need to give a thank you to the social EM team, Drs. Kachea, Sklar, McDonough, Graf, Gibson, as well as Dr. Aganor, Dr. Datta, and Dr. Gore, who all helped me with this presentation. Just getting into some definitions, intimate partner violence falls under the category of domestic violence, which really can be any type of violence that you've experienced from someone who's part of your family or that you live with, whereas intimate partner violence really refers to someone that you're in an intimate relationship with, not necessarily like in the same family, in the same household. It has multiple components, but can include things like psychological violence, which can be humiliation, controlling behaviors, financial abuse, as well as threats or other things. And then physical violence, I'm not going to go through every example of that, just basically any physical intent to harm someone. And then sexual violence, which is any sexual act or attempted sexual act where someone did not consent or cannot consent. Just of note, one thing I saw in the literature, just of language thing, there was use the term actually even still of date rape, which just my personal opinion, I don't think it's really a term that should be in the vocabulary anymore. All rape is rape, and by kind of qualifying it, it almost makes it seem like it's a lesser crime when we know that most cases of sexual violence are by people known to the victims. Sadly, it's a pretty big public health crisis in the US and across the world. Estimated rates from lots of studies that have been replicated have shown that women are expected to experience one instance of either rape, physical violence, or stalking by an intimate partner once in their lifetime, 1 in 3 people. And then for men, it's estimated to be 1 in 4. Just of note, some things about the different statistics that are out there. There is a lot of underreporting just due to the stigma and bias around these issues, which I'll talk about in a little bit. There's also a very in the most of the research, but it's improving now. There's very cis heterosexual lens that's put on the data. So at times today I'll be saying women, but I really mean that's just because of certain studies. But it's been replicated similar numbers in same-sex relationships, as well as it's been estimated that people who are LGBTQ minorities who are gender nonconforming or trans have experienced even higher rates of intimate partner violence. People might have kind of like a stereotype of what they think of as a domestic violence victim, but really it can happen to anyone regardless socioeconomic status, race, gender, anything. So just keeping that in mind, and I'll try to have my language be as inclusive as possible today. I apologize if at times I'll slip up. And then health outcomes for these patients. So sadly, the most tragic outcome in intimate partner violence is fatalities. Suicide actually accounts for a high rate of these deaths, but also homicide. 10% of all homicides from 2015 to 2019 in the US were from intimate partner violence, as well as I just wanted to make this point about a large percentage of deaths were attributable to intimate partner violence had visited the ER at least one time for an injury in the 2 years leading up to that. So it does point that there are times for intervention in the ER where we maybe could make a difference and try to prevent some of these outcomes, because of this data, only 4% of those individuals had actually been to a domestic violence shelter. And then pregnancy is a very high-risk time in relationships. It's been shown to be when abuse can start, as well as increased rates of abuse during pregnancy and postpartum period. If you are pregnant, you have a 3 times higher risk of experiencing intimate partner violence than your counterparts, and that's accounting for, people of the same age and gender as you. And then chronic health effects from this, really any type of chronic pain syndrome you can think of has been linked to intimate partner violence, as well as psychological effects, anxiety, depression, suicidality. So why aren't we really talking about this issue when it's so prevalent? There's a lot of reasons that go into it. One is a historical context. This really wasn't in the cultural conversation until about the 1970s with the rise of the feminist movement. And then additionally, there's just a lot of stigma and shame surrounding this issue. I think it can be viewed as, a women's issue, which historically and even still today, our government doesn't invest as much time, attention, or resources to. Additionally, if if you view this as something that happens to women, it's harder to identify yourself as a victim if you don't identify as a woman. Additionally, I think there's, casual acceptance that violence happens to certain people in our society. And that calls into play of like sexism as well as racism. And then just cultural gender norms. So it's knowing the context of the patients that you're treating. We treat a lot of Caribbean patients here. I was looking at one study that looked at 5 Caribbean countries and found that basically if you had the belief that men were supposed to lead a home, that women should stay at home, you were much more likely to experience intimate partner violence than your counterparts, or if you had been married before the age of 18. Those things, it's not just in the Caribbean, that translates to United States and worldwide as well, but maybe in some countries where there's that traditional mindset is more prevalent, just being aware of that. Sadly, in medicine, like we don't exist in a vacuum. We've all been exposed to these biases, these stereotypes our whole lives. So it is, not our fault, but our responsibility to try to educate ourselves around these topics, know what our patients are up against. Even if you yourself feel very educated, it's important to know, what they might be experiencing in their own minds or in their communities. And just of note, like the AMA, I think said that a quarter of medical schools get no training at all on trauma-informed care. And so it is something in medicine too that we don't talk about as much and sweep under the rug a little bit more than some other issues. So getting into medicine in the hospital setting, I want to focus today's lecture on things that we can do in the ER, like tangible things rather than just the larger issues. So 2 examples stood out to me from medical school that were 2 cases I had and interactions with the doctors who took care of them. So the first one, I had a charge nurse come tell me and the doctor that I was working with that the patient was coming in. It was a mother and her son. They were coming in because the father had tried to murder them by stabbing them. He was not successful. They had no life-threatening injuries. And the first response from the doctor was, "Oh, what did she do?" He was attempting to make a joke and make light of the situation. I honestly think it comes from like feeling uncomfortable with engaging with topics that feel very, very difficult to engage with, but ultimately just exposed ignorance and bias and was pretty disappointing response. I didn't see him actually take care of the patient. He might have done a great job. It's just was my interaction with him. And then the second case, I had a patient who had been brought to the ER. She had been there multiple times before. She was had facial trauma from her boyfriend hitting her. But the doctor took her to a private room, assessed her, treated her wounds, emphasized that she cared about her health and safety. She did nothing to deserve this. The violence is not love. She gave her resources and emphasized that the ER would still be there for her in the future, knowing that this patient was still planning to go back to this partner. So one of those is ones that I really wanted to exemplify and the other less so. But I thought she did a good job of kind of implementing the tenets of trauma-informed care. So I didn't really know what trauma-informed care exactly was. I've heard it thrown around before, but basically it's something that applies these 6 tenets in the surrounding circles to the care of patients. So understanding the broader issues, emphasizing their safety and agency is really like the main points of it, which is important, especially in caring for patients with intimate partner violence, to not recreate dynamics of like power and control that are paternalistic and assuming you know what's best for them, telling them what to do. So today we're going to talk about how we can employ this during the history, physical, and treatment of these patients. So first in the ED, how the screening process works. So it happens first in triage. It's not questions in the ED that we ask to everyone. When I talked with the triage nursing, they were saying you just wouldn't have time to ask every single patient if they had experienced intimate partner violence, but they will ask if the patient, discloses, or if they have injuries. They will sometimes ask for certain signs that are suspicious for that. But sometimes it's missed in triage, and so we're the first person that is actually getting this information. These were cited in the study as being the most common barriers in this order to screening from physicians. So kind of some of the things that we talked about earlier. But here are some red flags of things that you can look out for as reasons that you might want to start the conversation with the patient about asking about abuse. So if they have injuries that don't really line up with the explanation that they're giving, if they delayed coming into the emergency room, visiting the ER frequently, how they're acting in the ER. So if they're very like tearful, jumpy, fearful, avoidant, not making eye contact, or their partner's behavior. So concerning signs of behavior would be if they're like answering all the questions for the patient, controlling, or like verbally abusive. You definitely want to make sure that you get your patient alone. We'll talk about that in a second too, just of how you start these conversations. These are some risk factors for increased times of dangers in relationships. Sadly, the more like health and safety seeking behaviors that you have, the more dangerous it is. So I think a lot of times as the abuser starts to feel like they're losing control and will lash out. But additionally, it's just sometimes that the victim is recognizing that their life is actually in danger. So with starting the conversation, these were the factors that were identified as being the most likely to have the patient disclose this information, which is important to know, what's going on with them, and we can connect them to resources. So just starting very open-ended and very simple, not like even necessarily having a list of screening questions. I think this actually tends to go better for patients if you just start the conversation, see what they're willing to offer, and go from there. Making sure they're alone and safe in it. So if the partner is there with them in the ER, separating them, or, it's hard sometimes in RER, but trying to have like as much confidentiality as possible, even being aware of what you're saying on rounds about the patient as well. And then body language too, like level with the patient, make eye contact, speak in a concerning manner, that, you are taking this seriously. And these are just some examples of ways that you can start the conversation. It doesn't have to be the first question of acting like, are you being abused? But more so just asking what happened or asking about the nature of their relationship. An example, I had a patient in CCT. She came in because she said someone hit her. She was walking down the street, someone hit her with a bottle on the head. So we treating her wounds. She kind of frequently was jokingly saying like, am I going to die? Am I going to die? Or no, we're going to fix up your wounds. You're going to go home. But then at one point I just overheard one of her friends say to her, like, if you keep doing this, you're going to die. So separated her, got her alone, just kind of started the conversation, and found out, actually it was her boyfriend who hit her. Her mom had died from, intimate partner violence. So that question that she was asking was actually like much more indicative of her personal situation and traumas. So then we were able to connect her with resources, but she left the ER with a much more comprehensive care than when she initially would have come in and left for if we just treated her head wound. So history taking, there are some things that you want to get really specific information about. So you want to know what physical traumas actually occurred. Definitely always ask about strangulation. And then you do also need to know that if they had any gunshot wounds, any stab wounds with like the intent to kill, both of those you have to report to the police legally. And then you have to ask about presence of children. We're all mandated reporters. We could have a whole other lecture about ACS and the issues surrounding that. But if you ask about the presence of children, you have to, and they were there, you have to report it. So social work, I was talking to them, they said it's best that if we find out that information to just get as much details as we can, because there's times where social work goes back and then they're not able to actually get the information because now the parent's concerned about ACS and other things. So you have to get like the ages, where they were, where they are now. And then other things to ask about sexual abuse. Sometimes we're able to activate SART if it wasn't activated in triage because on further history, yes, there has been sexual abuse in the last 72 hours, but that might have not been what they came in for because it could be normalized in their relationship or they have something else that's more on their mind. Throughout your history taking, obviously, be supportive of these patients. Recognize that, this is very hard to talk about for them. One thing I say to every single patient that has experienced sexual violence or intimate partner violence is this is not your fault. It might seem oversimplified, it might seem obvious, but it actually can be the first point that you're giving a counter narrative to this person and starting their healing process for them rather than re-traumatizing them. I had a patient once who the main thing that she was focused on, even though she had experienced sexual violence, was the police officer's questioning of her. She asked me about it many, many times and was just very upset by the fact that he made her feel like she had done something wrong when she was asking for help. So we want to focus on healing and not re-traumatizing patients. These were things from a meta-analysis identified when they interviewed women regarding what they want in providers and what they don't want in providers when treating them in the ER. So non-judgmental, confirming the violence is not deserved, trying not to, recognizing our language when talking to the patient. So saying things and framing it all from, the abuser is the one doing the abuse, not you like receiving abuse. And then additionally, don't ever address this with the partner. That could become very like unsafe for you, unsafe for the patient. Don't ask why they didn't leave. Don't pressure them to leave. They appreciate more when we recognize that these situations are very complex. Not only is this a person that they love abusing them, but also they might be using threats against them, have much more complex social situations. So leaving is not always the safest thing, and it's not always what they're ready to do. And then additionally, just not like assuming guilt of our patients. I see this more in patients with penetrating injuries like gunshot wounds or stab wounds, where we say, well, oh, that can't be what it happened. They can't have been walking down the street and just gotten random violence. I think at best, this is an attempt to try to separate something that random violence doesn't occur or to justify something that's unjustifiable. But that's what it is at best. At worst, it's either like racist or in the case of intimate partner violence, like sexist at times. And a lot of the work around trauma-informed care that we do for patients of traumatic violence was stemmed from the work that was started with trying to develop guidelines for dealing with patients who have been victims of intimate partner violence. So on your physical exam, you want to make sure you look out for any red flags, so injuries of the face, genitals, defense wounds on the forearms. Additionally, if there's bruising of different stages, obviously give them autonomy throughout the exam. If they tell you to stop at any point, listen to that. Documentation is super important for these patients, as well as we'll talk about with SART later, patients of sexual violence, but you need all objective detail. Never say anything like accused or alleged or reports or denies, just say what they said happened. So you can say patient arrived after being punched by partner. You don't have to add in any narrative to that. And then also for having as many pictures in the chart as possible. If you have no access to a camera, drawing pictures in addition to like on the Epic drawing, in addition to your descriptions. And then even with ordering imaging, like it can be another source of objective detail. If there's an x-ray showing soft tissue swelling, like that is another just form of evidence for these patients that will ultimately be in court. And then letting them know the medical plan, treating their pain. So we always consult social work for every single one of these cases. These are the resources that social work will give. One thing also just in terms of safety, if you're concerned about keeping the partner away from the hospital, you can in Epic, there's like an FYI flag. I did this for inpatient patient once, where you can basically put FYI, this person is not allowed to visit this person in the hospital. And then if they come to the hospital, they'll be turned away by security at the door. And then Safe Horizon is the resource that social work will give to these patients. So they have 24/7 hotlines. Shelter placement, they'll do a whole intake assessment, find them a local shelter with availability. Additionally, they have other hotlines that are on the paper for talking about, the legal resources as well as sexual assault. These are also resources that Safe Horizon offers. So for child abuse, there's child advocacy centers, and we're proud to report that. There's community programs. They also can connect them with like locker placement. And then Family Justice Centers is the other resource that we'll give them. They really do comprehensive care. It's Monday through Friday, 9 to 5, but of all the things that might be affected and to try to help victims kind of get their lives back after leaving a partner, because it can be very hard based on financial situations or legal situations. This is how the information looks in terms of how to get there, and there are ones in every single borough. We give them a piece of paper that has all of it. Additionally, other legal options. So the Family Justice Center is probably the best one. You could always also give the referral for the NYLAG, which is free legal assistance, as well as other Brooklyn law firms do pro bono work, but that would be more like on a case-by-case basis. And then knowing their legal options. So knowing that they can press charges, you can offer that to them in the ER, as well as restraining orders. The only ones that I've found to be protective are actually permanent orders of protection. Temporary restraining orders haven't really found to be protective in these situations in terms of outcomes. And then, yeah, social work will just be doing all of this with the patients, but it's something that you could reinforce as well. Or if for some reason they don't meet with social work, or you're working in an ER where there's not a social worker available, just knowing all the resources to connect someone with. These are other just national hotlines. They even have text options if they're not able to talk out loud, as well as chatting. And then there's ones for people who are hearing impaired. And then that's just like the state one. All of them will kind of do the same thing, which is connect you to local resources in your area, trying to get you set up for as well as safety planning, which is a huge part of the DISPO for these patients. So social work also mentioned just circling back with them, like, yes, the patient might have seen social work, but just confirm with social work that they've done the safety planning before discharging them. Because that's one of the things that can be, protective in the future for this patient. Part of safety planning will include things that they should do in times of escalating conflict if they're going back to this relationship. So avoiding rooms that are have hard surfaces or weapons, like the kitchen with knives. Additionally, having an emergency kit, having a place they can go, someone that they can call, or a signal to call 911. This is just an example of the type of safety planning that people will do. It's pretty comprehensive, involves in terms of your emergency kit of all the things you would need to be able to quickly leave a situation, trying to keep it away from the abuser. So like all of your important documents and papers and things. So additionally, for survivor safety and empowerment, just giving referrals and follow-up appointments, having them have a follow-up appointment is just another doctor who can check in on them, reinforce, they'll be able to see your own notes. One thing about notes I didn't mention earlier too, if the patient asks you to not put in the chart of like who the abuse occurred from, you should follow that. They're allowed to ask for that. It also could be protective if that person has access to their medical records. And then mental health referrals are very important. So you can always follow up in the R building. Some other things are the NYC well, which is they can text 998. It connects them with all different mental health professionals. It might be for some patients preferable. Dr. Arcatea has a good dot phrase for it, so you could steal it from him on Epic. Again, all this information I'm going to send out to you guys. And then suicide resources, suicide safety planning as well, if they've endorsed to you that they're experiencing depression or suicidal ideation. Obviously too, getting psych involved in the ER if it's something that you're concerned about and is high risk. And then a last plug to take care of yourselves with these issues. We've all had our own experiences in life and can be difficult for us in different ways, but also just these things are hard with patients. The more that we like emotionally engage with them, the more that we kind of take on. So just taking time for yourselves, whether that's on shift, talking to other people, as well as mentors. There's the Helping Healers Heal like organization too. Sometimes it can be very hard with these patients because you're discharging them, but it doesn't feel like a safe discharge. That can be because the abuser just is very dangerous, or also just because the patient is not ready to leave that relationship. And it's just something part of accepting sometimes that we can't control things, but giving these parents, these patients as much support and advocacy as we can while we have them in the ER.